with alcohol metabolism mind map. Let's try and brainstorm and remember those dependent effects of alcohol on the CNS, alcohol absorption, factors that influence it, the steps involved in the metabolism of alcohol and enzymes involved, and the consequences of alcohol metabolism and toxic effects of alcohol ingestion, and just a quick overview of alcoholic liver disease. So remember the effects of alcohol consumption. The acute phase could lead to CNS dose, CNS depressant, which is dose dependent. So the plasma concentration has or has a direct correlation with the expected effect. So let's take a plasma concentration of about 30 to 100 milligrams per deciliter could lead to anxiolytic symptoms, euphoria, excitation, hesitation, restraint, caution. They are all lost. There's impaired coordination, mood and feeling are altered. By 100 to 150 milligrams per deciliter, there's mental clouding, ataxia, disorganization of thoughts, and impairment of memory and drowsiness. With 150 to 200 milligrams per deciliter, there's sloppy, ataxia, drunkenness, slurring of speech, loss of judgment, and inhibition. With 200 to 300 milligrams per deciliter, there's stupor, unconsciousness. So alcohol absorption depends on gastric emptying, which is also dependent on full or fasting state. So it's faster on empty stomach, slower with foods like carbohydrates, fats, and proteins in the stomach, and is absorbed into the hepatic portal vein to the liver, where you have the first pass metabolism before it enters into general circulation. First pass metabolism occurs higher in men than in women. Hence, men tolerate alcohol relatively better than women, and the absorption is by passive diffusion, which is dependent on concentration gradients. Increased concentration of alcohol means increased rates of diffusion, and two places in the body of for alcohol metabolism. The lining of the stomach, very little contribution from the lining is needed, and with the liver is the primary location. The ethanol is converted when it comes to the metabolism of alcohol. It's converted to acetaldehyde by the enzyme alcohol dehydrogenase with the help of the coenzyme NAD plus and zinc as a cofactor. So in the process, NAD plus is reduced to NADH. And remember, there are three classes of enzyme alcohol dehydrogenase. The first class, class 1, has higher affinity to ethanol than the other classes. Class 2 become important at increased alcohol concentrations, and class 3 is the same as class 1. The affinity increases with higher alcohol concentrations. So ethanol to acetaldehyde to acetate. But from ethanol via alcohol dehydrogenase to acetaldehyde, acetaldehyde could be converted back to ethanol, and acetaldehyde can go into the blood that causes a toxic hangovers. Alright, so still on the alcohol metabolism, the conversion of ethanol to acetaldehyde is a reversible reaction, like I said, and acetaldehyde is very toxic and responsible for the hangover effect of alcohol, and can diffuse easily into the blood to cause its toxic effect. The liver has to quickly metabolize it into acetate with the enzyme acetaldehyde dehydrogenase in a reaction, which also require NAD plus as a coenzyme. And this step is irreversible. With alcohol flash response, or the Asian flash syndrome, deficiency in acetaldehyde dehydrogenase 2 enzyme is what causes it. There's a build-up of acetaldehyde. This induces catecholamine release, and characteristic flashing response of the skin of affected people is seen. Yeah, so it's common in people of Asian descent, and 36% of the East Asian population is being affected. So the acetates produced can either stay in the liver or move into peripheral tissue and are converted to acetyl-CoA, and by the enzyme acetyl-CoA synthase in the mitochondria or acetyl-CoA synthase 2 in the cytosol. And as more and more ethanol is metabolized, there's increase in cytosol NADH via alcohol dehydrogenase pathway, and is increasing mitochondrial NADH via the reversible acetaldehyde dehydrogenase pathway, which accounts for 90% of alcohol metabolism. So with microsomal oxidation system, it accounts for less than 10% of alcohol metabolism, and ethanol is converted to acetaldehyde by the enzyme CYP2E1 and is a cytochrome P450 enzyme. It plays a minor role in ethanol metabolism, but becomes important at high enzyme concentrations of ethanol. It removes excess ethanol, produces reactive oxygen species, which is in high concentrations can be toxic to cells and can damage DNA, cause cell injury, toxic byproducts too. CYP2E1 in the presence of excessive ethanol can be upregulated, leading to tolerance mechanism in people with alcohol problems. So CYP2E1 then converts the acetaldehyde to acetate, and acetaldehyde dehydrogenase is still more important than CYP2E1 for this step. More NADH is produced and more acetyl-CoA2 is being produced, and this accounts for 10% of ethanol metabolism. And total ethanol metabolism combined is at a rate of 7 grams per hour, and that is like 1 drink per hour. So ethanol, under the influence of CYP2E1, reactive oxygen species are being produced, and as a byproduct, while the ethanol is being converted to the acetaldehyde by CYP2E1, and the acetaldehyde through CYP2E1 could be converted to acetate while there's release of reactive oxygen species, or the acetaldehyde could be converted to acetate via aldehyde dehydrogenase enzyme, and this reduces NAD plus to NADH, and then the acetate will be converted to acetyl-CoA. So the toxic effects of alcohol on liver metabolism, remember all the reactive oxygen species being released, and the this causes more damage with the consequences of NADH plus increasing levels of NADH, reduced levels of NAD, and also increasing levels of acetyl-CoA, so that dysregulation of glycolysis could occur, which can lead to lactic acidosis and there's alteration in the TCA cycle, and also suppression of gluconeogenesis. There's also suppression of fatty acid oxidation, leading to which leads to fatty acid synthesis. And so glycogen lactic acidosis could occur, also alteration in the TCA cycle, like I talked about. When it comes to the liver and alcohol, remember alcohol dependence is neither necessary nor sufficient for alcoholic liver disease. Dependent drinkers do not always have significant liver disease, and alcoholic liver disease may occur in non-dependent drinkers, though it's considerably common amongst them. The alcohol may cause acute and chronic toxic effects to the liver, and the severity um, of chronic liver disease is related to the amount and drinking of um, the duration of drinking and the person's vulnerability to liver damage and associated liver disease. So, what effects does stopping and reducing drinking have on severe liver disease? When a patient stops drinking or stopping drinking can considerably and quickly improve the liver function, and this organ has remarkably has a remarkable regenerative ability. So even if the patient cannot stop drinking but can reduce their consumption significantly, the decline in liver function may not only reduce but cease or even improve. That's those related toxic effects of the alcohol. But is alcoholic cirrhosis reversible? There's a widespread view that established cirrhosis is irreversible. The liver transplantation after 6 months of abstinence had significant improvements in liver function, no longer needing liver transplantation. This suggests that even established end-stage cirrhosis can improve with abstinence, implying that cirrhosis never becomes completely irreversible. Survival rates from liver transplantation. A number of case series have been published, and they find end-stage alcoholic liver disease accounts for over 30% of liver transplantation. The 5-year survival rate after liver transplantation is around 70%, and the estimated 5-year survival rate for those with a comparable stage of liver disease not receiving liver transplantation is around 23%. Right, so that is something brief about alcohol metabolism.